Hello, welcome. Welcome everyone to episode 184 of our 98 Crisis Jam. I'm Chuck Browning, the Chief Medical Officer at Recovery Innovations, also known as RI. And I'm fortunate today to have a packed Crisis Jam full of interesting information. A lot of it ties into some of the pre-show stuff that we just talked about. Our main speaker today is going to be Phil Evans from ProtoCall, talking about Firehouse model and underwriting crisis availability. So really looking forward to hearing you talk about that, Phil. As always, we give a little background on the 98 Crisis Jam that you can go to our website, sign up for updates, see prior recordings, check out materials. Remember that you do have to register for the Crisis Jam and have it connected to the Zoom account, one Zoom account per one registration, so that making sure that your device's Zoom account matches up with what you register for to be able to gain access. So now we'll move into the latest crisis news. We've got 3 or 4 updates, I think, today. The first touches base on a recent publication put out by Boehringer Ingelheim, a pharmaceutical company who was looking at multiple different barriers to clients and patients in there that were dealing with schizophrenia. And with last week's episode on early psychosis, there was a lot of talk in the chat about stigma. And one of the findings top 3 findings related to challenges with access to care. And one of the findings of this whole discussion was barriers to access. But one of the causes of that was thought to be stigma related to the diagnosis, even with the medical system having stigma about how to help support folks with this diagnosis. So please check that out in the link provided in the chat to be able to see some interesting information on that. We're going to be talking a little bit later on today. Carissa in the SAMHSA section is going to talk about 988 Day, and about the 988 Day activation workshop coming up. And the link is already in the chat for that. But I think Carissa is going to touch base on that when we get to that section. All right. So I think last week we talked about an opening. Speaking of underwriting capacity and access for crisis care, we talked about an opening last week in Maryland. Now we're talking about a new opening in the Kirkland area near Seattle, where Connections is opening the county's first walk-in crisis care center. And if you can see, this is an image of prototype of the typical 23-hour observation and treatment center, where it's the real gatekeeper that really maximizes emergency care systems and diversion from emergency rooms and law enforcement. I want to see if Chris, if you are on this, would you like to just speak real quickly? Let me see if I see you. Yeah, there you are.
Hey, everybody. Thanks, Chuck. And thank you for highlighting this. I guess July 29th is going to be known as like National Announce a Crisis Center Day, because you had your event in Maryland. And in addition, we had our event out in Seattle, King County. And it's also my wedding anniversary. But we're super excited. We had a lot of, and at the current moment, I think your presentation on the Firehouse model speaks well to the fact that it really does take a village to stand up these centers, as you all know so well at RI International. And it's just been a major community effort from the 5 cities, the county, the state, and all the leaders that participated in the opening last week. It was just a great success. We're really close to opening our doors in the next coming days. So everybody's really excited in the community to offer really in the Pacific Northwest, the first type of center that Arizona has enjoyed, and SAMHSA has made a national best practice around the country. So we're super excited about it. Look forward to sharing our outcomes and continuing to partner with all the crisis advocates on advancing this great work. So thank you so much for highlighting it. It was so coincidental when you all reached out and we saw online that social media that we both did our announcements on the same day, but it's just speaks to the need and the great work that we collectively do to give a national best practice operator to come into communities and serve this unmet need. And like I tell people, when there's an unmet need, there's a way, and that's what we've been successful collectively in doing together. So thank you, Chuck, for highlighting the pictures, and there was some nice press on it as well. So I really appreciate that.
Thank you, Chris, and we'll look forward to you being on our panel after Phil's discussion as well.
Okay,
and
great.
On that, in that same lane, but just a little bit over, is another resource we wanted to share with you. With connections, our very often frequent contributor to the Crisis Jam, Dr. Margie Balfour, and our friends of both of these folks, and Dr. Matthew Goldman, who has been in directing direction of care and crisis systems in the Seattle area, in King County area. And so they have this new Crisis Services and Issue of Psychiatric Clinics of North America, volume 47, as a resource that had about 13 major practice-oriented topics. And the link here is how you can access this information and be able to see the latest and greatest being put out and organized as the co-editors from Margie and Matt. And now we're going to get into our crisis hot seat. So today we do not have a particular person in the crisis hot seat, and there's a reason for that. We're putting the audience into the hot seat. This is the third total time that this question has been shown for our audience over the years in our Crisis Jam, and it's actually one of the questions that has been the most challenging to have a correct, consistent answer from the audience. So 3 times the charm today. We're going to get this covered and then our voting. So here's the question. Phil Evans, who's going to be presenting in very shortly, is our CEO and president of ProtoCall Services, runs one of the largest crisis call networks in the U.S. He says the first and most important element of an effective crisis system is simply making it accessible. So fill in the blank, audience. Phil often says a crisis provider must have the minimum funding required to blank core crisis availability. So is it coordinate, implement, supervise and train, or underwrite? D should be underwrite. So let's get these votes. So we're going to, I guess when we think through this, some of the questions have been really split in audience answers over the past few crisis jams. So let's see what our answers and what the audience come up with this time. Move to the next slide. All right. So we have got our answers looking like we've got coordinate, implement at 41%, supervise and train, and D, it should be underwrite. That wasn't the question, but unfortunately the poll had to implement, had at 27%. And so the correct answer actually is underwrite. I'm going to blame us not getting that on the third charm as the audience because the underwrite was missing as the answer. And so I didn't correct it fast enough to emphasize. But as it says up in the answer, crisis services that are sustainable mean the cost of training, hiring, ramping up, volume variability, and more are covered, both in startup costs as well as ongoing costs. And I think that's really important when you think about this discussion that we're talking about and what Chris just shared as this Firehouse model and being able to provide access, is that if you don't have these things covered, you're going to have 2 types of folks in your area, in your community, being able to do access, either not having enough capital to be able to get it done, so they can't, or they have the capital to get it done, but they won't because it's a money-losing situation for them. So good question to push forward and introduce our main presenter today, which is Phil Evans. Phil, are you able to come on?
I am. Thanks, Chuck.
Thank you.
I was so excited to hear that this Firehouse model question has been revisited several times. I didn't realize that, so I was thrilled to be asked to come in and talk about it. I think that an important distinction, we talk a lot about the importance of capacity, and what I want to talk about today is drilling down even farther to that part of capacity, which is really about availability. And I'm going to share a lot of things today that you all already know, no matter what part of the crisis continuum that you're working in, whether it's a crisis line, mobile crisis, or crisis receiving centers, that there is this inherent unpredictability of the needs that we serve. it's in taglines like BHL's "A Crisis Has No Schedule," or protocols "At Times We're the Only Answer," or BHR "We're Always Here." So we we live, eat, and breathe that aspect every day. So I want to drill down a little bit to this question of what it means to have the minimum funding to underwrite availability. So let's go to the next slide, and we'll go into the Wayback Machine here and talk a little bit about how we learned that lesson, because at our organization we didn't always understand that. This is an article from 1995, and yes, that is a very it's a 29-year younger Phil Evans there in that grainy picture, with a head full of hair. What we were doing at that time as the nonprofit suicide crisis hotline in Portland was looking to leverage our capacity by using our available time that our staff had. Now, what a great idea that we would be able to resell that availability to other organizations that needed to be able to have a paid, well-trained crisis counselor available 24 hours a day. And you can see in that quote there that we had a particular framework around that. It's important to understand, we said, actual costs. Nonprofits have a tendency not to know how much things cost. Maybe they have capacity that isn't being used. And so, next slide. That's exactly what we did, and it was wildly successful in a way. We grew the nonprofit's budget by 150% a year through that division that we called ProtoCall Services at that time. So between 1993 and 1996, we were going gangbusters. We brought in 100 new funding sources separate from the county funding that we were so dependent upon. And we were generating revenue at per call of $5 to $7 for every call that we took for what essentially felt like the icing on the cake or gravy. And we nearly grew ourselves out of business. We practically became one of those case studies in an entity that grew too fast, because what we didn't understand at that time, what we thought of as excess capacity, was really the critical availability that needed to be funded all along, or at least a portion of that was. And we didn't understand what portion of that we needed to have there. We thought it was all just coming in right on top. So the realization at that point by 1996 was that we needed to go back to those 100 new funding sources and explain to them why it is that their rates were going to go up by 3 times, because that's what we realized was missing, that we had been only capturing about a third of those costs. So all of that then is really our connection to the Firehouse model, right? This idea of the inherent unpredictability that we always deal with in our work, combined with the need for speed, equals the need to value that availability. And when I talk about availability in this sense, I literally mean the time waiting for the next thing to occur, the next phone call, the next dispatch, or the next guest arriving at the front door. In our call center, that is literally the time that a counselor is waiting to reach for that answer button on the phone. And in our world, that's the only way that we're going to be able to answer that call in 30 seconds. Because if they're doing something else, if they're otherwise occupied, even on something that maybe they could shift in a little quickly, it's going to be too late to meet those metrics. So the unpredictable nature of crisis services is its variable rate of arrival. And you combine that with service level goals, and those are what we think of as defining the minimum to underwrite our availability. That's how you get to that. Now, next slide. And that's really, I think, the same for all of us in one way or another. Even though the math may be different, the inputs are going to be maybe not numbers of phone calls, but distance traveled. Those sorts of things are define all of that. But across our continuum, every second counts, and every minute matters. Next slide. So the Firehouse model emphasizes the critical importance of the time being spent just being available to respond to a behavioral health crisis. So that's what we mean by that minimum chunk of time. And by the way, I've been told that I should point out a personal connection in this photograph. This photograph was sent to me last week by my son, who is this summer a wildland firefighter. So you can imagine that's not really very comfortable to get as a parent. So I found a way to put that picture to use. Next slide. So let's talk about this parallel with the Firehouse, and let's start with how we think about utilization in a Firehouse model. So for a Firehouse, there's what's called a UHU, unit hour utilization. It's the percentage of time in a 24-hour day that a unit is assigned to an incident, right? Meanwhile, the National Fire Protection Agency has set some standards for how quickly a fire department should be able to be on scene. And that's 5 minutes and 20 seconds for not less than 90% of the dispatched incidents. So we've got this question of availability and speed, right? So what would you guess is the recommended unit hour utilization for a firehouse seeking to meet the standard? Specifically, then, that's how much of the time are they busy versus how much time are they waiting for that 911 call for the engine to roll? So take a moment and think about that. Pick a number in your head. We're not going to poll you on it. All right, go ahead. Let's show them the number. It's 10 to 30%. So think about that. Your local firehouse is if they're operating within the recommended range, they may be spending as little as 2.5 hours in an entire 24-hour period actually on scene, engaged in an incident. So let's go to the next slide and let's look at the parallel to that in our context. So I'm going to use protocols context here. The equivalent of a unit hour utilization for a call center is commonly referred to as agent occupancy. So that's the percentage of time that an agent is engaged in direct call taking. They're either talking with someone or they are finishing a call, doing a wrap up, or for a firefighter that would be termed mopping up, right? That's that chunk of work. Some of us who compare to outside the crisis call center industry know that call centers at large generally are looking for an 80 to 90% occupancy rate. So that means that less than 10 or 20% of their time is actually spent being available. That's because they have metrics that are nowhere near the kind of metrics that we have to reach. So a typical performance target in a crisis call center might be something along the lines of 90% of calls answered within 30 seconds or 80% within 20 seconds type of metric. So what do you think your percent of staff time needs to be is ready and available? And have you all, and we'll get into this, be a prompt for our later discussion, but do you have a sense of what that level of time is in your operation that simply needs to be spent waiting for something to happen in that ready and available mode in order to reach your goals? I'm about to share what it is at ProtoCall. Go ahead, next slide. What we understand in our operation is that 50% of our agent time is spent on the phone or in the wrap up after a call. So that's only about half. That's 50% occupancy. And of the remaining 50% of time, 37% of that is spent literally waiting for the call to come in. And that's what we found is necessary in order to have that 14, 15, 16 second average speed of answer, or to reach that 90+% of calls answered within 30 seconds. So for us, that was the big revelation for us years ago, is needing to build that in. And that's what capacity means in our environment. So that's the big takeaway around for the minimum to underwrite availability. So let's go to the next slide. And lest we should think that this is somehow, that these numbers are somehow universal and can be applied, I want to give a personal analogy and go back to the Firehouse here. So this is a map of Portland, and that's Portland Fire Station 21 up top, and down below you see where I live. I am 2.8 miles away from the Firehouse, and that's pretty good. Your homeowner's insurance is actually based on, in part, how far you are from a firehouse. It really defines some very important measures about the risk. So 2.8 miles is not bad. The goal I read is that it's less than 5. Next slide. But there's a caveat, because I live on a floating home, and my fire engine is not a fire engine, it's a fire boat. And that's the fire department that's going to need to come to our rescue if we ever need it, and it's going to need to come on the river. So all of a sudden, 2.8 miles takes on an entirely different scenario. This is a piece of equipment that has a more complicated coverage area. It will take longer to get to us, and its utilization is most likely going to be far less, going back to that 10 to 30%. My guess is, although I could not get this in time from the Portland Fire Department, I had asked about if they had a number, a utilization rate for Fireboat 21. But my guess is, or at least my hope is, that its utilization rate is actually less, because that means I'm safer, and that engine will be ready and waiting more of the time for me. And I think that's the big takeaway here in this slide, is that each of us have very unique situations, and the common goal that I would encourage us all is to find that number for you, so that you can convey that to your funding sources proudly, with the idea that this is the time that your teams are waiting for something to happen, because it's so important. And I think, oh, yeah, there we go. And there's another picture of my son fighting forest fires.
Thank you so much, Phil, for sharing the pictures, the personal pictures. Speaking of personal pictures, I'm assuming you cannot get an Uber to your house with it being in the middle of the water, correct?
I can get an Uber to the dock.
To the dock. Okay, there you go. So that's very, very cool. But a fascinating topic, and we're going to pull up our panelists. Chris is going to return, as well as David Covington. This reminded me so much, Phil, about some of the things that we've had in some other topics where you apply like systems engineering and those types of topics to our behavioral health field, such as John Franklin Sierra doing work about that in some of the California systems, and we've had production on that. It's really fascinating to me. Chris, comments, thoughts?
I thought it was great. I mean, it aligns, and I'm going to share something we use on the Hill and with policymakers across the country, comparing physical health emergencies to behavioral health and psychiatric emergencies, and kind of aligning that really tends to hit well with policymakers to explain the need that someone needs to be at the phone or at the crisis center or mobile response, whether or not the crisis, in preparation of the crisis. So, think those are great slides, Phil, and I'll be sharing something on the chat. That's something that we use regularly to kind of show the difference right now, currently in lack of parity between behavioral health emergencies and physical health.
And David?
Phil,
I'd love
thanks.
to hear your thoughts.
Yeah, thanks so much, Phil, for this presentation. And look, in the pre-show, Dr. Chuck, you showed a video of literally hundreds and thousands of people waiting in hospital emergency departments without active treatment, mostly being detained and secured, with people watching them. And there's a huge cost for those individuals being in that room. Chris, what do you think an average hospital ED visit is going to cost?
I would say about $2,000 a day.
Yeah, $2,000 a day is that system. So Phil, you're leaning into this great science and business math that you're leveraging fields, Phil, that have been around for 50, 60 years with call centers and mobile type services, as well as Christie's facility services. So there are all kinds of models out there. We actually, Paul Galdus and the McKinsey Health Institute team put together a resource at calculator.crisisnow.com to try to get to this. But at the end of the day, Chris, Phil, Dr. Chuck, there has to be the funding to support the medical, clinical, technical, in this case, peer, whoever's answering that phone or coming out on that mobile team, it has to be resourced and supported. And Phil, I think this unprecedented marriage we're seeing between federal and state with 988 moving forward has to extend to an unprecedented partnership between provider organization and funders to make sure that we are resourcing this. The funding is available if we can start to map things in the right way. But these costs have been typically hitting crisis providers and then leading to crisis providers not being sustainable. I'll mention just one thing that hit the amount of costs that came out of the great pandemic that rolled to the crisis provider. I'll throw another question at you, Chris. The cost of just personal protective equipment. Any idea what you spent on that during the pandemic?
That's a great question, and I'll say that I've been with Connections just over 18 months. I can get that back to you. I couldn't even imagine the cost of that, but yeah, I know we were open throughout the pandemic, and we followed all the safety protocols throughout. So. Yeah. I agree, as well as I know Paul talks about sometimes having to use agency staff to cover shifts.
Exactly. That's where I was going, Chris. No, that's perfect. We were stung. Those outside agency costs of filling a nursing or physician position, and we've always used that sum. These are 365 services. 24/7, you've got a hole that you can't fill with a full-time, a part-time, or a pool staff, and you've got to have that nursing role filled. You've got to have that doc role filled, that nurse practitioner role filled. In 2019, we spent right at $1.6 million on those outside agency costs. And in 2022, we spent $13 million
Wow.
on those costs. So Phil, this ability, if we're going to have a sustainable, predictable system, we've got to start to redirect those resources, do it in an intelligent way. And I love the methodology you shared today.
Thanks, David. You know, and just to drill home on you know, the Erlang C and the Monte Carlo simulations and all of those models, absolutely. And what we learned is it actually starts for us. Someone gave me this term years ago, and I forget where it came from, but this idea of poor pricing self-esteem is what we were accused of, right? This idea of you know, we can't ask for too much. And I think for the idea of standing in that value of that 37% of the time at ProtoCall that our call center agents are waiting for that next call, rather than trying to justify it by, you know, we can get additional revenue sources elsewhere. We can use that. We can resell it. We can reuse it in other ways, is actually risking us discarding the value of that. And I think we're making great progress. I'll tell you, we were thrilled at the movement when you know, early in the 988 rollout, when Vibrant and SAMHSA distributed their estimations of the cost per call. And we're looking at numbers that were, you know, 60, 70, 80, even $90 a call. And you remember from the slides, you know, in the mid 90s, we were thinking that $5 to $7 a call was like icing on the cake. So we really have come a long way. And I'm not sure that's enough just yet either, given all of the additional demands on the systems. But we're definitely making progress and standing in that value and recognizing internally, even in our own managers and our own supervisors, really working to curate and understand the value of the time that we're waiting for something to happen. It's the business that we're in.
Hey, Phil, we've got a few more minutes, and I've got a question that I put in the chat that I would love to throw to you and possibly David or Chris too, if you had any pearls about this. And that was, as I looked at the numbers that you shared, it basically calculated out that it looked like you would spend in every hour for protocol for your call center, your utilization, about 30 minutes in occupancy. And then of that leftover 30 minutes, it'd be a little over 10 minutes of availability time. And then the less than 20 minutes left doing other functions. And I had a question, any thoughts on what is the value of that availability time? Is there anything that you have pearls to share that you could support staff in that availability time that maintains their availability, right, and maintains their efficiency and performance during their occupancy time without impacting that? Or do you is it better to just let them be available?
That is a great question, Chuck. And I have to correct something, and I'm glad you brought it up, because I want to emphasize that 50% occupancy and that 37% adds up to 87% of an hour.
Oh, I thought you said
it wasn't
50% of the time.
I might have misled when I said it was 30% of the remaining. No, it's actually bigger than that. It's a third, more than a third of an agent's time is waiting. So that makes your question even more important. Of course, we all want to find things that are valuable. We do a lot of things in the call center context during that time, but they all have to be immediately able to be discarded, right? Like I have to immediately be able to stop that. If it's something that takes me a minute, 2 minutes, 3 minutes to transition away from, well, then I've already missed my service level target. So that would include things like we do a lot of distributed QI. A lot of our staff are doing QI on their own calls, on their own documentation, on others. Or like there's training opportunities that can be immediately finished. We got a lot of things like that. The key is that it has to be in seconds. I have to be able to go, oh, I'm done with that, and I'm answering the call, because otherwise I've missed the boat.
That's really valuable, Phil. It was fascinating to me just thinking about that. I think that's applicable to mobile teams, call centers, and other areas in all continuum of the crisis spectrum. But being most helpful with that. So those are the good pearls on that. And I think John Draper said similar, that using that as a time for professional development. But like you said, being able to just immediately pivot and get to the call when that available, so that you are available in that time. Yeah. Well, thank you so much today, Phil. That's a very, very interesting topic and really hits home with some of the things we've been sequencing over the past few weeks. Next, I think it's time to go to SAMHSA. And I believe Carissa is on today. Hey, Chris.
Hi, everyone. Good to see you. Thanks for having us on. I want to talk about something exciting today. We are planning what we hope is going to be the first of an annual 988 day for September 8th of this year, and then every year following, hopefully. And what that is a day to create positive buzz around 988 and its related activities across the country. Every year we'll probably have a different tagline. This year's tagline will be "No Judgment, Just Help," which came from our 988 formative research that we did last November. And then again, earlier this year that we released about trusted messengers. That was the big message that resonated with a lot of people across different races and ages and walks of life. So we're using that in our first 988 day. And our big call to action is for anyone involved in 988 or who wants to be involved in 988 to share this message with your community, with the people you work with or see every day, in whatever creative way you want to do it, and whatever fun way you want to do it, and whatever resonates with your community, and to share what you're doing online with the hashtag 988day. And then we will put it up on a wall and let everybody know what's happening. And we hope to be able to share hundreds of really cool and exciting things that people are talking about out there across America about 988 on 988 day, which again will be September 8th. And the first thing I wanted to draw everybody's attention to is we are doing an activation workshop next Monday at 2:30. And everybody's invited to it. I will share the link. We sent an email out to everybody who the TTAC has an email address for, but we can share it with the Recovery International folks right after this call. And if you would forward it to everybody in your listserv, that would be great. And you can sign up for the activation workshop, or you can watch it later because we're going to record it. But all that's going to be is we're going to talk about the day and what we think it can be. We're going to share some ideas that we've heard from partners across the US, and just open the floor up for conversation about what people want to do that day, what they're thinking, have a big idea sharing about how can we spread the word in a creative way. We will be creating a digital toolkit that will have some ideas and some materials that people can print and use on the day. That'll be available next Monday as well. And then we are putting up a website this week. Hopefully, we're working on that now, and we'll send around the link for that as well. And I just wanted to let everybody here know because, you're out there doing the work. It would be amazing if you would share in the day and spread the word about the great work you're doing and the availability of help for people.
Oops, I had it on mute. That's a shame point. So now I'd like to introduce our NASHMID folks, Dr. Brian Sims and Arlene Stevenson, to talk to us about things going on at NASHMID. Hey, Dr. Sims.
First of all, Chuck, thank you so much. This has been a wonderful jam, and to Phil for the very timely discussion. As far as NASPID updates today, just briefly a couple of them, but I wanted to begin by turning it over to my colleague, Arlene Stevenson, who's the senior advisor with NASPID, to speak on the webinar that's coming up. So Arlene, go for it.
Hi, thanks for having us today. I wanted to tell you about a webinar that we will be offering, Vibrant and NASPID. This webinar is called Successful Grant Writing for 988 Suicide and Crisis Lifeline Centers. It's very comprehensive, so it's going to be in two parts on August 8th and the 27th from 1 to 2 in the afternoon. The first part of the webinar will begin with some researching grant opportunities, which grants are the best to apply for, what is the importance of building relationships with funders, and a review of preparing for grants and standard grant writing formats. The second part of the webinar will highlight grant writing challenges, identifying some of the key elements of grant proposals, what makes them successful, and how to promote your organization with potential funders. We're going to end the webinar on the second day with some question and answer sessions. We're really lucky to have the speaker that is coming to talk with us. She's a trainer on this topic. Her name is Dr. Beverly Browning, and she is truly an expert in this field. She is the founder and director of the Grant Writing Foundation. She teaches grant writing at universities, and she's the author of only 48 books on grant writing. The webinar will provide some real-time captioning, ASL interpretation, and it will be recorded. So check the chat for the registration and information. And after registering, you'll get a confirmation email that will tell you about how to join the meeting. So we hope you can join us.
Righty. Well, thank you so much, Arlene. And I just want to remind folks that the link is in your chat box. So please feel free to reference that again, beginning tomorrow. The last piece, Chuck, I just wanted to speak a little bit on the most recent NASPID annual conference. Now, NASPID hosts a conference each year with the commissioners and with various division members that talk about specific topics. This year's focus has been around 988 and the papers that have been written in that regard. And while I won't go over all of the papers or otherwise, I wanted to just kind of centralize a theme that came out of this particular annual conference. And it's been about the amazing amount of work and resources and accomplishments that have taken place since the 988 startup in July of 2022. One of which, and there were a number of wonderful presentations throughout the annual conference, but I wanted to reference one that was more so towards the end. And this was a fireside chat that took place about crisis services, crisis standards, and beyond crisis services, looking ahead into the next year. Because we've had lots of discussions amongst all of the states and the jurisdictions about where 988 is headed, and looking at it in a very optimistic sense. So we had a diverse but wonderful opportunity to network with 4 individuals. Chuck Ingoglia, who's the president and CEO of the National Council for Mental Well-Being. We also had Kana Enomoto, who's a senior knowledge expert and associate partner with McKinsey Health Institute. We had Nanette Larson, Deputy Director of Wellness and Recovery Systems with the Illinois Department of Human Services, and Dr. Joan Galise, who's the director of our own NASPID Center for Innovations in Health Policy and Practice. These 4 individuals were absolutely phenomenal with regards to expressions about where things are. And what we did was we took a look at where 988 is, where it is going, some of the challenges, some of the resources, but basically came through with a premise that suggested that things are moving in the right direction. And this is a message that we'd like to have carried, because these 4 individuals presented local resources, their own conceptualizations, but it's part of a larger picture that really takes a look at where 988 is and how it is moving in such a positive direction. So I just wanted to make people aware of that, Chuck. And I thank you for the time. And I thank Sansa for the obvious opportunity and our participation with them. So back to you, Chuck.
Thanks, Brian. That was a great presentation at Nashville. And one of my take homes is I remember you just teasing Joan about how long you guys have been working together. So that was my big take home. Not really, but it was fun. It just hung in my brain. So Dave Atkins is coming in from Listen to talk to us a little bit more about how to be an informed AI crisis care consumer. But in light of this discussion of underwriting, anytime AI can increase the efficiency of the occupancy time of a staff person in this crisis support, it helps some of those equations that we were discussing, as well as many other things I'm sure you're going to share with us.
Yeah, thank you so much, Chuck. Great to be here as always. And today we are wrapping up a quick 4-part series on how to be an informed AI consumer. We've touched on really foundational issues like what is AI, what isn't it, key ingredients in AI quality, things like demonstrating that AI is valid, that it's reliable, that it's not biased. Last month, my colleague Zach Immel talked a little bit about generative AI, which has been center stage in popular culture, courtesy of ChatGPT. And today I want to talk a little bit about some of the use cases for AI in crisis care. I'm not going to be talking about specific products. That's not my role here, but just want to talk about where are some of the initial AI tools being developed within crisis care. Next slide, please. And to think about this, I want to highlight 2 kind of core functions of AI tools. And again, this is not AI as a general system, that kind of image of a robot AI. This is AI tools that have a specific purpose and were designed for a specific purpose. One of the things that AI is good at is identifying particular types of content or text. That could be in a conversation, such as a call taker, help seeker conversation, or in other settings. And AI is also really good at generating naturalistic, human-like text. And so where might this show up in crisis care? If you could click forward. We are often, either for training purposes, for supervision, or for quality assurance, we're wanting to find particular types of conversations, particular elements within conversations. And so AI has a nice match with that. Similarly, one of the things that we have to do is we have to document, whether that's the various types of calls or contacts throughout crisis care. And AI is pretty good at summarizing and writing a naturalistic summary. So let's take a little bit deeper look at each of these. Next slide. And by an interesting, happy coincidence, Listen is collaborating with ProtoCall, courtesy of a NIH grant, actually on this particular topic. So it's great to see Phil, and I didn't actually know you were going to be here. So one of the key things that we can do with AI is develop it to identify particular types of relevant content. And so if we have done that well and we've developed valid, reliable, and unbiased AI, then we can identify things like when is a caller making a risk statement? When are they talking either explicitly or passively about suicide? We can then identify key things that we would want all of our call takers to do in response to that. Things like assessing for current and past suicidality, and the severity, intent, whether there is a specific plan, means, and so on. Of course, human supervisors and quality managers can do this. And the advantage of AI is that ability to take that to scale, to be able to, as we have just celebrated 988's to your birthday and saw how many millions of contacts there have been, AI has the potential to go to that scale of millions of contacts and evaluating and pulling out key information that then we can use for training, supervision, and quality assurance. Next slide, please. In addition, all of those contacts have to be documented in some way. And oftentimes the core piece of documentation is just a quick summary of what occurred in that conversation or that contact. And AI is quite good at that. Stepping away from crisis care specifically within AI applications within healthcare generally, this is a very, very active area. What are the various ways that AI can speed documentation? And so some of the really big players in the AI world, OpenAI, Microsoft, and others are pursuing how AI can assist documentation generally. But this core element of how can we quickly draft summarize the content of a conversation or one of our contacts is a core feature of generative AI. Next slide. So here on Tech Corner, I give you just really almost kind of sound bites around AI in the amount of time I get. I wanted to let folks know that there's a upcoming webinar that I'll participate in along with Dave Jobs, Julie Goldstein, and Ursula Whiteside. And that'll be a longer, hour-long kind of open-ended conversation about crisis care and applications of technology. And so if you'd like to hear a little bit more and with various perspectives on that, would welcome you to join us here in a couple weeks.
Thank you so much, Dave. Appreciate you sharing those things with us. Tom, are you on?
I am, Dr. Chuck. How are you? Can you hear me okay?
I sure can. So
Excellent.
Stephanie unfortunately couldn't be here today, so I'm going to take the role of her part in this discussion. In this article, we covered this. It's kind of a reemergence, but I thought it might be good to take a look at this article and the hope and some of the things in it and apply the lens of it's been a year. Where do you think this has evolved or not evolved as we've gone through from last July to this August?
Yeah. So I think first, a shout out to Stephanie. She does such a great job in putting these articles together. I sort of follow her, and then she makes something come up that's incredibly thoughtful. So she does a wonderful job with the articles. I feel like, first of all, change is incremental, right? I think we all acknowledge that. There's been a tremendous amount of change as it relates to 988 and crisis systems here over the past year. And I think we've seen continued progress as it relates to the intersection of Medicaid coming to support the behavioral health infrastructure, right? And I think great proof of that is the Medicaid director letter that came out within the last couple of months out of CMCS. And we've talked about that on this calls in terms of some of the funding opportunities that are highlighted in that letter and ways for states to be thinking about financing options to help support 988 infrastructure and mobile crisis interfaces and other important aspects of the overall system design. And the article also touches on lessons learned from Lady Kate Aurelius in terms of the importance of being able to partner with individuals that have lived experience, and we continue to see that as an important aspect as well in terms of Medicaid and advisory committees, that members, individuals that are receiving Medicaid services to get input. And I believe that will continue to help shape systems for them. So ultimately, crisis systems are really one of those true rare opportunities in the healthcare delivery system where we can advance the triple aim, right? We can improve individual outcomes, we can reduce overall costs, and at the end of the day, we can improve population health. And to me, we need to continue all that we're doing in terms of support for the development of these crisis systems. It was great to be on this call today to hear about the Firehouse model. It's something that my mentor, Kate Aurelius, preached about all the time 15 years ago. And here we are today in terms of really seeing advance and the opening of new crisis service systems in different states. And so We're making incremental progress. I wish it would move more quickly. I know we all would wish it would move more quickly, but the progress is happening and we need to continue with our efforts in lifting this up. And I think this call is just a great example of that, where we regularly have a couple hundred people or more come together weekly to talk about the opportunities that are out there and how we advance this.
So, Tom, if I can, we've got a couple of extra minutes. If I could squeeze in a couple of questions I think are right down your alley. I don't know if you saw them in the chat. But they tie into this article too. But as we discussed the underwriting Firehouse model and some of the systems that Phil described, we talked about this availability time. I believe it was Andrew Guy that asked the question in the chat. Any thoughts on Medicaid CMS's role in being able to cover that cost and how to do that when it's not necessarily a billable service directly one-to-one with the person during that time, and it's a significant chunk of the time?
Yeah, I think Medicaid has a lot of leeway in establishing rates and how they think about rates. And at the end of the day, rates need to cover the cost of delivering those services for the Medicaid applicable piece, right? And part of that piece is to recognize the fact that there is sort of this downtime associated with it. When you look at all of the infrastructure that exists to pay for ambulances and other things like that, when you look at most states, they have cost-based reimbursement. That cost-based reimbursement looks at downtime as it relates to having the infrastructure available. And so, again, I think Medicaid has a lot of discretion in how they think about this, and they need to think about this, in a broad sense in terms of all the various factors that lead to the costs of supporting the infrastructure.
Got one more question to ask for your expertise, David Pearls. So earlier, again, when we were talking about during Phil's talk, Phil used the term poor pricing self-esteem in advocating for the costs and the funding that's needed to truly underwrite all services. David called it standing in our value, related to a term that we use at Recovery Innovations. Any pearls on systems as they're setting this up, being aware of that dynamic and partnering with the funders that be and entities that be to avoid that, so that they really can get the capital to support and underwrite startup and continued access to care?
At the end of the day, Medicaid agencies want to get this right too, right? They don't want to create something that is going to fail. To help really succeed, organizations lean on those individuals that have the expertise. Right? And so being able to bring information forward to your Medicaid partners, to your managed care organizations in terms of what the true costs are, I think, most people are open to receiving that information and trying to make systems work. And so you need to bring information forward, and you need to present it in a way that's going to help inform individuals what the true costs are of maintaining these systems. And so I think that's incredibly important in terms of being able to help educate those that are having to make very difficult decisions in terms of, oftentimes lack of, the type of information that's necessary to set rates. We could sit and talk finances all day, Chuck.
I still appreciate you taking the extra time to help cover some of the questions in the chat. So very much appreciate it. Thanks, Tom.
Thanks, Dr. Chuck. Take care.
And just one other piece as we're getting ready to close, as we were covering that, Phil said it's just really important to know and know what your costs are. And so I think that's one of the lessons to take home from this, is continued improvements in our understanding of the business math, the systems engineering of these types of things as we roll them forward. So really excited about the close of today and all the things that we covered and how they all interlace together. My dear friend, Joy Brunson and Subaga, is going to be in our next episode presenting a special topic on medication-assisted treatment services connected to crisis care. So really looking forward to her presentation next week. And then in the next episode, 186, Sarah will be presenting, works with the Trevor Project on special topic of 988 and LGBTQ plus youth specialized services. So please mark your calendar for both of those. And then August 28th, as it says in the chat, we'll mark it because we will be live at a hybrid meeting during that. Also really appreciate all the comments in the chat, helping support some new ideas for some new topics that multiple people listed. Hey, we'd like to hear about this, and hey, we'd like to hear about that. please continue to put those in the chat, as well as send in emails and contacts, so that we can continue to bring content that's meaningful and informative, as well as inspirational towards our movement of continuing to drive this care forward. Thank you guys so much for your time in this Crisis Jam. I always appreciate doing this. I need a good sign off like Dr. John Draper has, but I don't have one for today. But thanks for watching. Bye.